نجي نتعرف على البلمونري امبوليزم. خلينا نعرف شنو البلمونري امبوليزم. Pulmonary embolism is an obstruction of pulmonary artery, major pulmonary artery or one of its branches by a material. This material called an embolus because it comes from, it's not formed in situ, it's formed elsewhere in the body and migrated via bloodstream to the pulmonary circulation where it obstructs the blood flow. Is this disease a common disease? Yes, it's a common disease. It's a very common disease, and with increasing frequency of performing pelvic surgery, especially in females, the incidence is increasing, and with the increase in the detection rate, the pulmonary embolism incidence is also increasing. The overall incidence is approximately 0.6 to 1% annually. This slide shows the types of emboli, which could be air, fat, clots, which is more common, the most, tumor or septic emboli, and amniotic fluid embolization. قبل ما نحكي عن الكلينيكال فيتشرز او نتكلم عن الكلينيكال فيتشرز اوف pulmonary embolism، راح نسوي مراجعة ل some basic physiological pathological facts about this disease. We will speak about the blood coagulation system and the physiology of pulmonary circulation. Okay. The blood need to be to flow freely in the small tiny capillaries, and this needs that the blood to be in constant fluidity state, not to clot when it passes through, and this is maintained by the anti-thrombotic system. However, once the blood is or the blood vessel is injured, the blood should be able to form clots to seal this injury. So the blood contains both thrombotic systems and anti-thrombotic system, and these two systems that are present in the blood are in critical balance. So the blood fluidity is maintained by both functional and anatomical integrity of the endothelial cells lining the vasculature. As you know that the endothelium is the vessels are lined by endothelial cells. These endothelial cells are very active system, involved both in maintenance of blood fluidity, at the same time prevention of hemorrhage by triggering thrombotic response when there is endothelial injury. So at the site of vascular damage, a lost endothelial function, it's not necessary to have only endothelial system. This system might be dysfunctional by toxic substances like tobacco, and so it might be present anatomically, but functionally it's not functioning well. So the antithrombotic property, when there is an endothelial damage or endothelial function loss, there will be a thrombogenic response. This thrombogenic response either triggered by loss of substances that maintain fluidity in case of endothelial dysfunction, or by exposure of the subendothelial thrombotic material that will be exposed to the blood when there is anatomical injury. In general, the coagulation response of the human blood involve the following phase. أولا هي الفاسكولار phase اللي هي تتكون من vascular spasm at the site of anatomical injury or endothelial injury. Second is the platelet phase, which involves initially platelet adhesion, followed by recall of another platelets, and we call it platelet aggregation to form platelet plug. And the third phase is the clotting phase, which involves activation of the clotting factors, which are nearly 13 clotting factor in number in both extrinsic and intrinsic pathways. So this diagram shows the process of platelet adhesion and platelet aggregation. The exposure of subendothelium will expose the subendothelial von Willebrand factor. The von Willebrand factor will bind platelets via glycoprotein receptor 1b. This glycoprotein receptor, this attached platelet or platelet adhesed platelet will be activated and secrete substances that recruit other platelets, and each platelet will bind other platelets via fibrinogen through the glycoprotein 2b3a receptors. This slide shows the contribution of the clotting factor to the process of coagulation. We've got two pathways, the first one, what we call it the extrinsic pathway, and the second one, what we call it the intrinsic pathway. The extrinsic pathway starts with the what we call it the tissue factor union with the factor 7, and this will convert factor 7 into active complex that binds the tissue factor, and this complex will activate the factor 10 and convert it into an active factor 10. Factor 10 active will convert prothrombin into thrombin, and this thrombin will activate fibrinogen to form fibrin monomer that will polymerize and form cross-link fibrin by the assistance of the factor 13. The intrinsic pathway involves the activation of factor 12 by the prokallikrein and high molecular weight kininogen. This high molecular weight will convert this active factor 12 will activate factor 11. Factor 11 will activate factor 9. This factor 9 will again back to factor 10, and it will activate factor 10, and then the process will continue in the same way as the extrinsic pathway. The process of activation of factor 10, we call it the common pathway. Factor 10 from and below, the sequences from factor 10 and below, we call it the common pathway. This slide is showing listing the list of antithrombotic mechanisms that are present naturally, which involves the presence of antithrombin 3, protein C and protein S, tissue factor pathway inhibitor, and the natural fibrinolytic system. And this slide is showing the after we got an overview of the coagulation and anticoagulant systems that are present in the human body. We have to know the classes of drugs that are available to treat thrombotic accidents. These drugs include vitamin K dependent clotting factors antagonists like warfarin, and fractionated heparin, which combines with the antithrombin 3 that inactivates factor factor 2, factor 9, factor 10, and factor 12. And we have the low molecular weight heparins, which contains only the active parts of the unfractionated heparin. It also attacks the same factors, 2nd, 9th, and 10th, and 12th factor, with a specification more on factor 10, and the direct thrombin inhibitors like dabigatran and rivaroxaban, which are orally available. In this slide, we will speak little about some facts about the pulmonary circulation. You know, the blood passage in the pulmonary circulation is in the same quantity that passes into the systemic circulation. However, this circulation is different from the systemic circulation in many ways. First of all, structurally, the pulmonary artery and its sub-branches structurally different from the systemic artery in a way that it has got thin elastic lamina, and it look like more like just like a vein, And this pulmonary artery, it can incapacitate large amount of blood without creating significant vascular resistance. The normal PA pressure is nearly about 1/3 that of the systemic pressure, and consequently the pulmonary vascular resistance is normally up to 1/10 of the systemic vascular resistance. In cases of pulmonary hypertension for whatever reason, whether in cases of congenital heart disease or in cases of pulmonary following an event of pulmonary embolism, the pulmonary artery will be exposed to chronically elevated pressure. This chronic elevation of pressure will create what we call it remodeling in the arterial wall structure. This remodeling will, we call it systematization, i.e. in another words, the pulmonary artery structure will look like just like the systemic artery in a way that it contains thick elastic layer that facilitate creation of high pulmonary vascular resistance, and this process of remodeling is an irreversible one and happens when there is chronic elevation of the pressure, or when there is obstruction of the pulmonary circulation that is not resolved for a long time. The other concept which we should know that is the concept of ventilation perfusion match. For each segment in the lung, there is a blood supply and there is an air supply, and there should be a matching between the areas of blood supply and air supply. There should be enough air for the enough blood in order to get full oxygenation. In cases of for example, areas of hypoventilation, the hypoxia in this area will stimulate pulmonary vascular spasm and will divert the blood from this area towards area that is well ventilated. In cases of pulmonary obstruction, there will be a blockage of the arterial supply to certain areas of the in the lung, and this will create ventilation perfusion mismatch. I.e., we've got a well ventilated area, but it's not a well perfused area, and this will be obvious in the what we call it ventilation perfusion scan. So this slide is showing the first sequence is the ventilation scan in different views, and the perfusion scan in different views. And once there is mismatching in that we could see the trace is being taken up in area of ventilation and not taken up in areas of perfusion, we call it ventilation perfusion mismatch. So what is DVT? DVT means the thrombosis of the veins, deep veins, not the superficial veins. Most commonly happens in the leg veins. It also can happen in the mesentery, in the upper limbs, in the brain veins. But these are very unusual sites and considered to be a mark of prothrombotic condition. So, in order to know the predisposing factors for or precipitating factors for venous thrombosis, we have to remember always the virtuous triad. The virtuous triad is a triangle of stasis of blood, means that blood flow, and the integrity of the endothelial system, and the hypercoagulability of the blood flowing in this vessel. So, in order to remember these factors, we have to keep in mind this virtual triangle. This slide is showing the predisposing factors for DVT pulmonary embolism. Most of these factors are very common in clinical practice. Many of people have got abdominal and pelvic surgery. Many of them have got hip and knee replacement. Pregnancy impertinence is also a very common condition. COPD, congestive heart failure, fractures, varicosities, abdominal and pelvic malignant diseases, and age and immobility. All these are common factors that are present in usual life, and therefore pulmonary embolism consequently will be common. For each of these predisposing factor, one or two or even three of the virtual triad factors can be contributing to the pathogenesis of DVT pulmonary embolism in these patients. So, how does patient with DVT presented? The clinical features of DVT include presence of leg pain, tenderness, swelling, feeling the veins cord-like, and somehow in a way or another and tender because of congestion, as well as dilatation and prominence of the superficial vein. When the patient presented with pulmonary embolism as a first presentation, only 10 to 30% of them we can detect the presence of DVT, and many times patients they have only minor symptoms of DVT, but they would have a massive or large pulmonary embolus. Approximately one-third of patient who are highly suspicious to have DVT would have other diagnoses like ruptured Baker cyst, and should be included in the differential diagnosis of any patient with calf pain in whom you are suspecting DVT. You should rule out the presence of ruptured Baker cyst. Regarding the clinical presentation of pulmonary embolism, really it depends on the size of the pulmonary embolism and the underlying condition of the patient. In general, we've got features of small pulmonary embolism which may pass asymptomatic or just minor shortness of breath or chest discomfort, or medium-sized pulmonary embolism, in which case the patient will suffer shortness of breath, hemoptysis, pleuritic chest pain, tachycardia, tachypnea, and clinically we could find a pleural rub, or in cases of more dangerous, what we call it massive pulmonary embolism, which presented as sudden death, cardiogenic shock, severe central chest pain or oppression, syncope, pallor, central cyanosis and elevated JVP, and loud P2, splitted P2 or gallop rhythm. Together, we could find, as we said before, we could have features of DVT or we could not have these features. This slide contains a table that summarizes the clinical features of pulmonary embolism. Keep in mind that the chronic pulmonary embolism, we've got acute massive pulmonary embolism, acute small to medium-sized pulmonary embolism, and chronic pulmonary embolism. We speak about the acute massive and acute submassive or small or medium-sized pulmonary embolism. Like chronic pulmonary embolism is a consequence of first attack, I've either repeated minor or medium-sized pulmonary emboli or survived acute massive pulmonary embolism, will end up with chronic pulmonary thromboembolic pulmonary hypertension, will end up with chronic pulmonary thromboembolic pulmonary hypertension. You know that every patient with pulmonary with any clinical diagnosis, we should have what we call a differential diagnosis, because diseases share same symptoms, same signs, same signs in different percentages. So in a patient presented with features that make us suspecting pulmonary embolism, we should rule out the presence of MI, we should rule out the presence of aortic dissection, pneumonia, pneumothorax, and musculoskeletal chest pain as major differential diagnoses of patients with pulmonary embolism. This slide lists the way of investigating patients with suspected pulmonary embolism in order to prove the diagnosis, and we will pass quickly over them one by one. First of all, chest X-ray. Chest X-ray might be very helpful for providing additional evidence for the suspected patient with pulmonary embolism. However, normal X-ray is the rule in patients with pulmonary embolism. What features we could have in patient with pulmonary embolism? We could have wedge-shaped opacities. We could have different shapes and size pulmonary opacities, horizontal and linear opacities. We could have pleural effusion, elevated hemidiaphragm, enlargement of the main pulmonary artery, and oligemia in the lung field. The what we call it Westermarck sign, which is an oligemia of the of lung field, which is an abrupt termination or pruning of the major pulmonary artery, as we probably see in the right upper zone of this chest X-ray. And the other sign is the Hampton's hump, which are pleural-based wedge-shaped opacities, indicating peripherally located emboli, as we can see here in the in this chest X-ray in the right lower zone. The second investigation that might be helpful in this area is the in the diagnosis of pulmonary embolism is the presence of ECG, certain ECG features. Keep in mind that the ECG most commonly contains nothing apart from sinus tachycardia. We could have features of pulmonary right side enlargement. We could have features of acute RV strain, what we call it S1 T3 Q3, which involves prominent S in lead 1 and presence of Q wave and T inversion in lead 3. We could have tall R in V1. We could have deep symmetrical T wave inversion in mid-precordial leads in V1 to V4, also together with the presence of sinus tachycardia and right axis deviation. Blood gases are also helpful. Blood gas analysis is also helpful for the diagnosis of pulmonary embolism. In general, the classical finding of patient with pulmonary embolism is the presence of hypoxia and hypocapnia. Hypocapnia happens because of rapid ventilation that leads to depression of the reduction in the CO2 content and what we call it metabolic respiratory alkalosis. One of the most important blood investigation is the D-dimer. The D-dimer is a plasma protein that's specifically produced after lysis of cross-linked fibrin by plasmine system. The levels are almost elevated in the presence of acute venous thromboembolism. So measurement of D-dimer level is a sensitive test for recent DVT and pulmonary embolism. Keep in mind that this this part of cross-linked fibrin is not specific. It means that it can form in any site, any place where there is a process of thrombosis, like recent surgery, like trauma, like also arterial thrombosis, venous thrombosis, DIC, whatever the possibilities that any process of clotting present in the body will have an elevated levels of D dimer. Also, many hospitalized patients with acute acute illness and many patients with malignancies have elevated lower titers of this D dimer. So it's not a specific, and therefore it should be interpreted with the clinical context. The role of D dimer assay therefore is limited to helping the exclusion of pulmonary venous thromboembolic disease when the index of suspicion is low. It's helped for exclusion rather than proving the diagnosis. This slide shows the gold standard for diagnosis of pulmonary embolism is the CTPA, CT pulmonary angio. This slide shows these black filling defects in the main pulmonary artery and showing the main pulmonary artery, and the proximal right and left pulmonary artery contains large thrombi. This is the gold standard for the diagnosis. It has an accuracy about 98% for diagnosis or exclusion of pulmonary embolism. Echocardiography and Doppler ultrasound are very helpful tools. They are non-invasive, they are easily available, and can be brought to the patient bedside, especially when the patient mobility is limited. And these are very helpful in diagnosis of DVT and diagnosis of pulmonary embolism. This is a VQ scan that demonstrates the presence of ventilation perfusion that depends on on demonstration of ventilation perfusion mismatch. Its main use is in the pregnancy, because in a pregnant lady with suspicion of pulmonary embolism and which for the sake of radiation exposure يعني احنا نحتاج اذا احتاجنا imaging study to prove pulmonary embolism بالpregnancy نحتاج نسوي VQ scan rather than CT scan because of very much difference in the radiation dose that is present in the CT scan, and which is much lower in case of ventilation perfusion scan. Pulmonary angio is an old tradition before the invention of CT, and now is a very limited use for the diagnosis of pulmonary embolism. In every disease, we should have a plan for workup, and this algorithm will help us in picking up patients with suspected pulmonary embolism. First of all, we have the assessment of the clinical risk, whether this patient is highly suspected to have pulmonary embolism, depending on certain factors which we will speak about, and measurements of D dimer. If the patient falls in the low risk and D dimer comes negative, then everything is okay. The patient has got confidently no DVT or pulmonary embolism. However, if the D dimer comes positive and the patient is high risk, then we have to treat, and together we have to confirm the diagnosis. For a patient who is low risk, who is low suspicion risk, and D dimer tend to be positive, we have to continue our workup, and according to workup, we will decide whether to treat this patient or not. If D dimer comes negative and the patient is high risk then also workup including CT. This D-dimer will not affect the suspicion, and we have to go on to approve or disapprove the diagnosis by other more specific tools. These slides show how can we classify the patient as high risk or high probability or low probability for the pulmonary embolism. Any of these factors are listed here. Will give us give us increasing probability of being a case of pulmonary embolism. So a score of 0 will indicate low probability. A score of 1 to 2 indicates moderate probability. A score of 3 and above will indicate high probability. After making the diagnosis of DVT-PE, we have to speak about the management. First of all, before we have to prevent in every disease. We have to think of prevention of the disease before it happens. Then, if the disease happens, we have to speak about its treatment. How do we prevent DVT-PE? Is by taking prophylaxis. Prophylaxis is the single most important measure for ensuring patient safety in hospitalized patients. It involves the following tools to prevent PE, specifically in high-risk surgeries, including compressive stockings, prophylactic anticoagulation, early mobility and calf massage, and management of risk factors. These are very important measures that we should take in patients exposed to risk conditions that make DVT chance to happen very high. This slide is explaining how compressive stocking do its job in preventing DVT. So we'll pass then to the treatment of patient with proved pulmonary embolism. First of all, we have to have the first pharmacological agent to be chosen patient with pulmonary embolism is the anticoagulation. The duration of the treatment of patient with pulmonary embolism depends on the whether this presents just DVT or whether it's DVT plus pulmonary embolism, or it depends also on the presence and persistence of the provoking factor. Generally, we have 3 months in patient. The duration of treatment is for 3 months in patient with the provoked DVT without pulmonary embolism. It's for 6 to 12 months for patient with unprovoked DVT, or those with PE, or those with PE. And in cases of unprovoked or patient with recurrent DVT pulmonary embolism, the duration of treatment will be lifelong. Fibrinolytic therapy involves the use of thrombolytic drugs. It's indicated for patients with massive pulmonary embolism of submassive, though, but still high-risk patient. This slide and the next 2 slides contain different case scenarios for patients with pulmonary DVT pulmonary embolism, and will be left for discussion in the Google class or in the Zoom application. By this slide, the lecture of DVT-PE will be ended. Thank you very much. Thank you for your patience and listening.